Our last speaker is Monica Nandwani from Stanford. Monica serves as one of the nurse practitioners at the Stanford Esophagus Center, where she is involved with motility interpretation as well as education to multiple physicians and APP trainings. She also is now manager of the APP at Stanford Health Care Center for Advanced Practice, where she provides administrative support for the organization's over 500 APPs. And today she's going to be giving a talk about advanced practice providers in gastroenterology, something that has really hit close with our group. And we recently added Sandy Saul from Stanford to our board to help chair a subcommittee for APPs. So thank her for her time and look forward to this talk.
Thank you for the introduction, Nick. And I would like to thank the NCSCG for the opportunity to present today. I would like to thank the conference organizers and the board, particularly the APP board members, Sandy Saul and Josie Gomez, for inviting me to speak. And I was actually informed that this is the first time that there has been an advanced practice provider presenter in this forum, so I'm very excited to be here. And I thought, what better topic to discuss but advanced practice providers in gastroenterology. I have no disclosures, and these are my objectives. And so when we talk about advanced practice providers as a group, which professionals are we referring to? And to be perfectly honest, when I first moved to the West Coast from the East Coast in 2016, I had actually never heard of the term advanced practice provider. However, over the last few years, this term, advanced practice provider, or APPs, has been increasingly common, and it is inclusive of the following professions. So when you say APP, it typically includes nurse practitioners, or NPs, physician assistants, or PAs, certified registered nurse anesthetists, or CRNAs, certified nurse midwives, or CNMs, and clinical nurse specialists, or CNSs. And the reason I bolded NPs and PAs is because this tends to be the types of APPs that you see in gastroenterology practice, unless you're in the endo suite, and then you'll see some CRNAs in the endoscopy suite. Now, in the past, advanced practice providers have been referred to as mid-level providers, physician extenders, non-physician providers, non-physician clinicians, and allied health professionals. So all these different terms can sometimes be a little confusing, and we're really trying to move away from these terms and as a collective be identified as advanced practice providers or either our specific role, which is NPPA, and so forth. So I just thought I would spend a little time talking about nurse practitioners and physician assistants and a little bit of background about these professional roles. So I am a nurse practitioner, and so I have my bachelor's in nursing. I had to take a licensure exam to be a registered nurse, and I went on to get my master's, which is my family nurse practitioner degree, and I actually practiced for about eight or so years before I went back to get my terminal degree, which is my doctoral degree. And a lot of programs now are actually moving towards nurse practitioners having a doctorate as entry into practice. The nurse practitioner profession was established in 1965, and as of 2020, there's actually about 290,000 advanced practice providers within the U.S., equating to over 1 billion with a B patient visits per year. So very robust presence of nurse practitioners. As far as practice, we do need to pass a national board certification exam, and we need to renew every 5 years through continuing education credits, and our licensure is by state. As far as physician assistants, typically our physician assistant colleagues have bachelor's degree plus a 27-month or 3-year master's in PA studies, and we also have colleagues who have doctoral degrees in PA studies. The PA profession was established in 1967, and as of 2020, there's about 140,000 PAs within the United States, equating to over 400 million visits per year. Our PA colleagues do have to undergo national board certification with recertification every 10 years, and licensure for our PA colleagues is also by state. And so why are we talking about APPs in gastroenterology? So as many of you know, There is an estimated shortage of primary care physicians, about 54,000, and specialty care physicians, about 139,000, according to the Association of American Medical Colleges. Now, I knew I was going to be presenting to a group of gastroenterology clinicians, so I really wanted to dig a little deeper and look at what the specific shortages were for subspecialties. And if you look at the U.S. Department of Health and Human Services data, by 2025, the greatest shortage is actually predicted for cardiologists, with a predicted shortage of 7,080 full-time equivalents, followed second by gastroenterologists with a projected shortage of about 1,630 FTEs, so 1,630 FTEs of gastroenterologist shortage by 2025. And this is followed by hematologists, oncologists, and pulmonologists at around 1,400 FTEs respectively. Now let's contrast that with the projected growth for NPs and PAs. So if you look at the U.S. Bureau of Labor and Statistics website and you look at their Occupational Outlook handbook, they list the 20 fastest growing occupations in the United States. So these are the 20 occupations with the highest projected percentage change of employment over the next decade, so between 2019 and 2029. And if you look here, nurse practitioners are second only to wind turbine service technicians, with a projected growth of about 52% over the next decade. And for physician assistants, they can come in at around ninth, so within the top 10 growing professions, with a projected growth of about 31% over the next decade or so. And so with this increasing demand of gastroenterology care, lack of supply of gastroenterologists, and you can see the growth here of advanced practice providers, APPs really provide an option for expanding digestive care to our patients. And so I wanted to review a little bit about NP and PA scope of practice. And in practice, NPs and PAs actually function very similarly. So we can order, perform, interpret diagnostic tests and procedures. We can diagnose and treat acute and chronic conditions. We can prescribe medications. We can develop treatment plans and provide patient education and counseling. The main difference between NPs and PAs is really that the educational training that we undergo. So NPs are trained in the nursing model, whereas physician assistants are trained in the medical model. For NPs, practice authority is determined by state laws, whether it's full, reduced, or restricted practice. And just as a side note, California is actually one of the most restricted practice laws for nurse practitioners, which is changing. I'll talk a little bit about the new legislation in the next couple of slides. And then for physician assistants, again, PAs are trained in the medical model, and most state laws do require that there's an agreement with a specific physician or surgeon in order for PAs to practice. So if you work in a practice that has APPs, you've probably heard the terms collaboration or supervision, and these are really dictated by individual state laws, and then again by organizational job descriptions, policies, and bylaws. And I think this topic is probably so huge and is a separate talk in itself, but I did want to give a little bit of an overview. So individual state laws will say, is there a requirement for a collaborative or supervisory agreement with a physician in order for an APP to practice? If so, it'll define the level of physician involvement when APPs provide care. So for example, does the physician need to be physically on site, or is remote supervision acceptable? And if they need to be physically on site, is there a specific percentage of time when the APP is providing care that the physician has to be on site? Additionally, state laws indicate what services can be provided. So here in California, the scope of practice of a nurse practitioner is that of an RN plus standardized procedures. And so at Stanford, we have standardized procedures, and we get privileged to perform extra functions such as procedures like paracentesis, et cetera. And then state laws also determine prescriptive authority. And in all states, APPs are able to prescribe medications. However, in certain states, for example, if a PA has to prescribe a controlled substance, it might require a physician co-signature. And that's actually changed a little recently here at in California, as there have been two pieces of new legislation affecting NP and PA scope of practice. And so Senate Bill 697 affects PAs, and this has been effective since January 1st, 2020. And Assembly Bill 890 affects NP's scope of practice, and this was actually very recently signed into law by Governor Newsom on September 29th, 2020, so just a couple of weeks ago. And a high-level overview of these legislative changes. So SB 697, which relates to PAs, essentially replaces the Delegation of Service Agreement, or the DSA, with a practice agreement, which defines the medical services that a PA is authorized to perform. Basically, one of the great things about the passage of this bill is that it actually reduces the administrative burden on physicians and PAs, as it no longer requires medical chart review or co-signatures by supervising physicians. And that being said, at Stanford, we're still requiring some of these things based on the old legislation, as we're working to update our specific policies and bylaws within the institution to reflect the changes in this legislation. Assembly Bill 890, which was passed just a few weeks ago, establishes the Nurse Practitioner Advisory Committee, and that consists of 4 nurse practitioners, 2 physicians, and 1 public member. What this Assembly Bill says is that beginning January 2023, it would potentially authorize nurse practitioners to perform functions without standardized procedures, as long as they meet certain requirements. So I don't want to spend too much time, but just a heads up that there has been new legislation affecting NP and PA's scope of practice. So this is where I want to spend most of the time for this lecture, is really talking about the role of advanced practice providers in gastroenterology. And so as many of us know, about 60 to 70 million Americans have digestive diseases, leading to about 105 million clinic visits annually. And as clinicians, we know that diseases of the GI system greatly impact our patients' overall quality of life and are associated with some substantial direct and indirect costs. As a significant portion of the United States population will require digestive care at some point in their lives, adequate access to GI preventative, diagnostic, and treatment services is really crucial. But this is problematic, given, as we saw in the previous slides, that there is a shortage of about 1,630 full-time equivalents of gastroenterologists by 2025. So again, this continued demand and lack of supply of gastroenterologists, APPs really provide an option to expand digestive care delivery. And so I actually gave a very similar talk to this in DDW back in 2018. And back then, I actually reached out to the different professional societies, including the AGA and the AASLZ, to find out what was their APP membership. And at that time in 2018, the AGA had over 550 APP members, and AASLD had close to 300 APP members. And I'm involved with the Gastroenterology and Hepatology APP Society, which was formed about 3 years ago. And as of this year, GAP has over 800 NP and PA members. And then about a couple of years ago in 2018, JAMA Internal Medicine actually looked at how many specialty practices, including GI practices, employed an APP. And at that time, but in 2016, about 1 in 4 GI practices employed an APP. And I have a few more slides showing that information coming up. And so I actually recently joined Twitter. I'm very new to Twitter, for those of you who are on Twitter, and so I don't have a lot of followers, but I thought it would be fun to poll the GI Twitter community to see how many gastroenterologists on Twitter actually work with an advanced practice provider. And so a few weeks ago, I posted, as an advanced practice provider in gastroenterology, I would like to ask the GI Twitter community, how many of you work with APPs in your practice or group? And I gave the heads up that this will be used for an upcoming presentation. Thank you in advance. And I was actually very surprised to see that I had 47 respondents, despite the fact that I had just joined. And about 85% of those respondents actually said that they worked with an APP, which I thought was really great. So I thought it would be fun to share those results with all of you. And I know Twitter is not that scientific, so I'll show you a little bit more thorough data here. And so again, going back to the JAMA Internal Medicine 2018 publication, looking specifically at SK&A data set, which is a proprietary data set that includes information on 90% of physician practices in the US. So they looked at how many GI practices as a percentage had advanced practice providers, and they compared data in 2008 versus 2016. And I kind of made those numbers a little larger because I know it's hard to see on the screen. But you can see that in 2008, about 25% of GI practices had an APP, and that increased to about 28.7% in 2016. So about a 14.2% increase in that 8-year span or so. And you can see what the breakdown is by NP or PA. And so looking at the literature about APPs in gastroenterology specifically, although publications discussing utilization of APPs in the field of GI are limited, the available literature is encouraging and has demonstrated positive outcomes. So looking specifically at nurse practitioners in GI, they've been shown to have positive outcomes in patient populations including post-colonic dissection, irritable bowel syndrome, dyspepsia, and dysphagia. I did want to spend a little time talking about APP role, as this can vary based on the type of practice. So whether you're in a private practice versus an academic practice, if the APPs are working inpatient versus outpatient, or perhaps a hybrid role, which means both inpatient and outpatient. And again, a lot of times, institutional policies and state regulations really dictate what's within our scope of practice as an advanced practice provider. And so a little bit of recap about roles and responsibilities of advanced practice providers. And I think many of my phenomenal APP colleagues who are inpatient at Stanford are on this call right now, so I'm so glad to see them here. But our inpatient APPs at Stanford are actually our primary service line. And as part of their inpatient duties, they perform admission history and physical, daily rounds, hospital care management. They coordinate referrals, arrange endoscopic procedures, organize discharge, and ensure patient follow-up. And the reason an APP primary team was established is because it really helps with care continuity for patients, because oftentimes fellows might rotate in and out of the service and might not be familiar with those long-term patients. And so we've found that having APPs as part of the multidisciplinary care team has really been quite effective. For outpatients, so that's where I've spent most of my career in a GI. In the outpatient setting, APPs can be involved either in independent or shared clinic visits. We triage phone calls and health portal messages, discuss diagnostic test results and treatment plans. We coordinate care and provide patient education and post-admission follow-up. Perhaps one of the most exciting and growing areas of involvement for APPs is procedural. So in the East Coast, we have some colleagues that are performing endoscopy procedures, including upper endoscopy, colonoscopy, and flexible sigmoidoscopy. That was actually part of my fellowship program at Hopkins when I completed my one-year GI fellowship program. Our inpatient APPs and even our outpatient APPs at Stanford perform paracentesis on our patients. There are some APPs in the country that perform liver biopsies. Motility study interpretation was a large part of my practice, breath test interpretation, and clinical trials. So I do want to say that in addition, in the academic setting, our APPs play a large role as well with education. So whether that's education of APP students, so our inpatient team always has students from the Stanford PA program, spending time with them, whether it's education of fellows, so our APPs inpatient actually train some of our newer fellows in paracentesis. I've trained many colleagues with motility study interpretation. And so this is, I think, in the academic setting is a really rewarding part of my role that I have found. And so one thing I did want to talk about is if you're thinking of adding an APP, or if you already have an APP, one of the important things is determining practice fit. And I will say that most GI APPs do not undergo formalized postgraduate training, and most of the learning is on the job. There are 3 APP fellowships that I'm aware of. So the one at Hopkins, which I completed, and I believe there's one at Swedish Medical Center, and AASLD has a hepatology fellowship as well. So if any of you are aware of any fellowship programs for APPs, please let me know, because I would be curious to learn more. I think it's important to assess the needs of the practice and tailor the APP role. So this is an old photo of the motility group at Hopkins, and this is probably, I don't know, 7 or 8 years ago, and you might see some familiar faces there. But at that time, when I went through my fellowship, the motility program was just starting. And so I was fortunate enough to learn from Dr. John Clark, and I had an interest in motility, and so I joined the motility group and was part of that group for about 6 years. And then I do want to mention that although it is a time investment upfront, I do highly recommend having an onboarding and orientation period that you can tailor based on the level of experience of the APP. And I think this time is really crucial because you can gauge working styles and compatibility, you can create efficient workflows, you can learn what the practice and the provider's diagnostic and treatment approaches are, establish a comfort level, really build a trusting relationship, and promote an environment for constructive feedback. I think when incorporating an APP into practice, it's important to establish roles and goals. So discussing the number and types of patients that the APP will be seeing. Will they be working with a specific patient population? So in my case, in gastrointestinal motility, or perhaps with the IBD clinic, et cetera. Will the APP be trained to perform any procedures? So again, our APPs at Stanford, for example, do paracentesis. Which team members or physicians will the APP will be working with? Will they have RN coordinator support or medical assistant support? Will they be given any administrative time, and what are the on-call requirements? And I will say that it is important to have a regular performance review to gauge how everything is going and what can be improved upon. And I think one of the really important things is to highlight the role of an advanced practice provider to both staff and patients. You know, when I first started in GI, a lot of patients really didn't know what a nurse practitioner, an advanced practice provider, or what a PA was. And so introducing them as a member of the team and how the APP will be part of the multidisciplinary care team is really crucial. And then as far as benefits for APPs in gastroenterology based on the literature and as well as my experience, as we demonstrated, you know, there is a huge demand for GI care, and adding additional providers will help facilitate earlier access to care, will improve patient education and satisfaction and provider face time. We hope that having APPs in the practice lead to better physician work-life balance. We all know that, you know, burnout is something that's very real and has been studied in the medical literature, and there have been studies showing increased burnout, and so having APPs in the practice can hopefully improve work-life balance and allow the physicians to focus on other activities such as research, endoscopic procedures, and complex patients. So in summary, NPs and PAs function similarly in practice, but we have different backgrounds. APP scope of practice and supervision requirements vary by state, and California has new legislation, SB 697 and AB 890, that was passed this year. There has been increased incorporation of APPs in gastroenterology over the last decade, as illustrated in that JAMA Internal Medicine article, with about 28% of GI practices as of 2016 having an APP. But according to Twitter, it's 85%. So I'm going to go with my Twitter poll results for that one. And then APPs work as part of a multidisciplinary care team to optimize patient care and satisfaction. APPs in GI can really increase access to digestive care, especially given the projected physician shortage. And I thought I would just end this talk with showing a picture of some of the most phenomenal APPs I've had the pleasure of working with over the years. And you might recognize some of the individuals in this photo, but some of them have masks on, so you might not be able to see their faces. that being said, this is the end of my talk, and I welcome any questions.
Thank you, Monica, for an excellent talk. We have a couple audience questions. One is, are you aware of any APPs performing therapeutic procedures such as polypectomy or any other kind of advanced therapeutics?
Yeah, so that's a great question. So when I was in the East Coast at Hopkins, our first, her name's also Monica, the first individual to undergo the GI-NP fellowship actually ran a colon cancer screening program for the low-income population in Baltimore. And she actually would do screening colonoscopies and would do polypectomies as part of that. And we actually just published an article about our experience of the first 1,000 patients that we scoped, and it was published in International Endoscopy Open just this month.
Cool.
For like larger polyps, we do refer to our physician colleagues. So.
And then the last question we had is, what are the medical legal implications? Are APPs liable on their own for their own actions, or is it in tangent with physicians?
Yeah, so I think it really depends on, so there's different kind of ways that supervising physicians can be potentially liable, whether it's vicarious liability, negligent supervision, or negligent hiring. And I think that might be a very large topic to talk about. So I think that might be something to review if you're thinking of incorporating an advanced practice provider within the group.
Well, thank you again for a wonderful talk, and we appreciate you giving your time on this beautiful Sunday.
Thank you.